Welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. I'm Bob Aksafa, and along with my partners, Drs. Greg Buncke, Rudy Buntick, Andrew Watt, and Walter Lin, we're delighted to welcome one of the true icons of reconstructive microsurgery, Dr. David Chuang from the Chuang Memorial Hospital. Professor Chuang is a full professor of plastic surgery at Chuang. I had the privilege of meeting Professor Chuang for the first time almost 2 years ago during my first visit to Taiwan. And at that time, we got to chat for at least half an hour after my talk about functional muscle transplants. And at that point, I was reminded that Professor Chuang that year in 2019 was to be the Harry J. Buncke Lecturer, which, as we know, is the highest honor that you can basically receive by ASRM, essentially a Lifetime Achievement Award. And so we spent a fair amount of time during a wonderful dinner discussing his Buncke lecture and also exchanging stories and slides about Harry Buncke and some of his early work in the laboratory. So a few months later, Professor Chuang delivered his Buncke lectureship address, which was a phenomenal talk on his very extensive experience with peripheral nerve, functional muscle transplants, and facial palsy and obstructure and brachial plexus reconstruction as well. And here he is after his award with Dr. Greg Buncke, who is the head of our clinic, and it was really nice to see him at ASRM. Now, Professor Chuang has achieved many accolades. He was the past president of the World Society for Reconstructive Microsurgery. This was in 2017, which was held in Seoul, Korea, which I believe was the highest attended WSRM ever. So it was a very successful event. As I mentioned, he was the 2019 Harry J. Buncke Lecturer. He's a past president of the Taiwan Plastic Surgical Association, the past president of the Taiwan Society for Surgery of the Hand. He's also a past president of Taiwan Society for Reconstructive Microsurgery. And clinically, he is incredibly productive. He's done over 2,000 brachial plexus explorations and reconstructions, and has performed over 1,000 free functional muscle transplantations, which is an incredible number, likely unmatched by anyone in the world. He's also an internationally renowned surgeon in other fields, so obstetric brachial plexus palsy, facial paralysis, peripheral nerve surgery, such as nerve injuries, compression neuropathy, and peripheral nerve tumors, and obviously other topics. I think all this is a result of being a disciple of luminaries in the field of microsurgery and peripheral nerve surgery, such as Professor Sam Nordoff, Professor Wei, Julia Terzis, Professor Malaysi, Professor Narakas, and Toru Kondo as well. So with that, Professor Chuang, thank you so much for being with us. It's really an honor and a pleasure to have you, and we're all greatly looking forward to hearing your wisdom today. Thank you so much for being with us. I'm going to make you the I'm going to make you the presenter now. Thank you. Go ahead. Sorry.
Thank you, Dr. Bob, giving me the so kind words. And I also want to thank you. I show my gratitude to you and to Dr. Greg Buncke, giving us a wonderful lecture before. So thank you. And to feedback, so I have this evening talk. I will present. Can you show the slide? Can show the slide?
Perfect.
I will present my past works, titled Complex Injury of Upper Limb, My Experience and the Sangen. Perfect. The next. Okay.
Professor Chuang, so it looks like part of the slide is not on the screen.
Not the slide, not on
the left part of the slide for some reason is cut off.
Yes.
Maybe if you can Perfect. That looks great.
Now, can you see whole screen?
Yes, that's perfect.
Okay. So my definition about the complex injury of the upper limb is if the injury involves at least three of the five tissue systems: skin, muscle, bone, vessel, nerve, we call the complex injury. It is a high energy injury which needs extensive and complex reconstruction. All reconstructing procedures are palliative, not curative, attempted to make a useless limb useful. People like to use such words to describe it: devastating, crippling, mutilating injury. There usually have many debates between the amputation and the salvage on this subject. In this particular time, I will present three subjects: traction avulsion amputation, so-called TAA; Volkmann ischemic contracture, so-called VIC; and major muscle and nerve loss. Start from the first subject, TAA, forearm and arm. It usually caused by high energy of injury by rolling machine, conveyor belt, or occasionally occur in the rupture rope by mass player of tug-of-war game I made. This is a different pattern of the rolling machine, even including the conveyor belt. This was an accident. 1,000 people play tug-of-war game in Taipei. It happened in 1997, October 25. That is one of our national holiday. 1,000 players. Once the rope rupture and all the traction force go to the winner side, and you can see the injury here. Two people has a TAA rupture in the arm area, as you see in the picture. Mechanism of TAA is when the forearm and arm is caught or entrapped by machine or by rope or by belt. Then which induce the high energy retraction force and cause the tissue avulsion. The so-called avulsion means you only can see the one cut stump in the wound with tissue crushing. If you want to see another stump, that will be in another place. Characteristic of the TAA is different from the guillotine amputation. The so-called guillotine amputation is kind of circular amputation, but with sharply divided and the local crush. So in TAA, you can see the skin is circumference avulsion with more crushing on one side. The vessel already mostly rupture close to the bone cut end. A nerve usually avulses from the proximal side. Muscle usually tear with severe crush. If happen in the tendon, they will disrupt it and the tendon-muscular junction, so-called musculo-tendinous junction. Then you can see the different pattern of the forearm TAA and arm TAA here. I propose a simple classification regarding to the TAA. Just it based on the disrupting point of the muscle and the nerve. It's not based on the fracture bone. So there are 4 levels. The level 1 is the rupture. It is the amputation at or close to the musculo-tendinous junction. Level 2 is amputation within the muscle belly and the proximal muscle still functional. Level 3 is at or proximal to the neuromuscular junction. Level 3. Level 4 is through the joint. We call it the disarticulation. There's 4 levels. It's based on the disrupted point of the muscle and nerve. I collected 27 patients of TAA patient with successful replantation, they will refer to me for further reconstruction. So at least 12 plastic surgeons involved this kind of initial replantation with different thinking process, so different management. So you can see more patients in the level 2 forearm and arm within the muscle, that being the TAA within the muscle. But still you can see often, very often through the joint, elbow disarticulation. You see, it's still open, you can see through the elbow disarticulation. But no one is shoulder disarticulation. Maybe probably because in the initial they don't implant, they don't attempt to reconstruct, to replant such kind of the severe injury. This information tell you what I collected, the information from the forearm type 1, from the forearm level 1 TAA, including the replantation hospital, bone shortening, vessel repair, nerve repair, tendon or muscle repair, later reconstruction, and the functional result. This is information I collected. I also collected information regarding to the forearm type level 2 TAA, collecting the patient information from the type 4 elbow disarticulation. Information collected from the patient with the arm type 2 TAA. This is an important slide, just tell you the tips for management of TAA. Bone shortening is always required, should be at least forearm 5 centimeter, arm 7 centimeter bone shortening. The benefits of that is to allow direct vessel repair, which can shorten the ischemic time and decrease the incidence of fasciotomy. If the ischemic time less than 4 hours, usually you don't need fasciotomy. And to enhance the quality of nerve repair is, to make the tensionless nerve repair. Debridement of the devitalized and dangerous skin and muscle should be aggressive. Sometimes you need to immediate free skin or myoclonus spray for wound coverage. However, for the nerve trimming, it should be conservative. I make such investigation among the immediate nerve repair versus early lead repair, that means within the 4 hours. Delay within the 3 weeks, and the delay, late delay nerve repair, that means 6 months or longer. There actually no big difference in the TAA patient. So I prefer immediate nerve repair, even the short nerve graft is recommended. In level 1 TAA, you can do the tendon to muscle suture, it's okay. But in level 2 TAA, muscle to muscle sutures, it's okay, sometimes okay, especially extensor tendon, okay, but not guaranteed. Usually you need the second stage function-free muscle transplantation. Level 3 amputation, level 3 TAA, because it's the neurotizer injury. So the all entire muscle you should remove because they are innovative and useless. You can take out all the muscles. The wound can be closed primarily. Then such patient already need second stage function-free muscle transplantation. In the level 4 TAA, they always need external skeletal fixation and immediate myocutaneous or cutaneous spray for wound coverage. The second stage function-free muscle transplantation is always required. But I recommend you can bone shortening of humerus 5 centimeter to allow primary repair of the vessel or primary repair of the nerve. This is recommended from my experience. Here are some case demonstration. This is level 1 TAA after replantation and the later tenolysis. You can see the such result is just 2 times surgery. Another case, forearm level 2 TAA after replantation, still no finger flexion. Extensions come back by itself. Then gratuitous come in for the finger flexion. So he got the finger flexion. This is another case for level 2 TAA. After replantation, after 2 gratuitous, 1 for extensor distal communis, 1 for finger flexor distal profundus and flexor pollicis longus. It's a 2-stage procedure. You can see the extension and the flexion. Another case, forearm level 2 TAA, after replantation, after the gratuitous for the finger flexion. Another case is level 3. Is level 3, and after replantation, you can see actually is after you can exercise all the the impact muscle and then direct wound closure. Then later stage, you do the function-free muscle, so you also get the finger flexion. This is level 4. This is original, coverage by the LD muscle. But now I recommend you, instead of use the muscle in the graft, it's better use the cutaneous spray or myocutaneous spray for wound coverage. So you can see after replantation and 2 gratuities, 1 for finger extension, 1 for finger flexion in different stage. This is on level 1 TAA. After replantation, the recovery of the extensor and recovery of finger flexor by itself. No other surgery, level 1. Another one, level 1 TAA, post-replantation, no flexion, no extension. So 2 gratuities, 1 for extension, 1 for finger flexion, get the same function. Another case, level 2 TAA, this is the case due to the tug of war game. So after replantation, the patient has good shoulder because this is the level 2 TAA is through the humerus within the muscle. The shoulder is good, so they can elevate the shoulder. Then I did a function-free muscle for elbow flexion. The patient did not want to do more surgery for the hand, so he only get the shoulder and elbow. Another case, level 2 TAA. You see the good shoulder. I still have the good elbow. I do the function-free muscle for finger flexion. This is level 2 TAA. After replantation, he got the elbow flexion, hand function, but no elbow extension. So I use a 2-stage procedure. One stage is using the radial nerve, Buncke nerve graft in the first stage. Then second stage, function-free muscle for elbow extension. So you can see get at least the M3 elbow extension. Another case, level 2 TAA. You can see 3 years after, 1 gratuitous for elbow flexion using the musculocutaneous nerve, 1 gratuitous for extensor using the spinal accessory nerve, and finger flexion will recover by itself. So you can see the 2 free muscles, 2 free tissue here, 1 for elbow flexion and 1 for finger flexion. Another case, level 2 TAA. You can see the 3 years after the gratuitous 1 for elbow flexion, gratuitous 2 for extension. So you can see the 2 muscles, 1 for elbow flexion, 1 for extension, using the function-free muscle. Another case, I'm level 2. So after replantation, like this, and stage 1 gratuitous for elbow biceps, and the stage 2 is the radial nerve elongation for the finger extensor. The finger flexion is recovered by itself. Another case, TAA and arm level 2, 2 gratuitous, 1 for finger extension, 1 for finger flexion. This is the TAA, actually is incomplete TAA in the level 2 within the arm muscles. So I did a gratuitous for the elbow flexion, because the elbow flexion, using the musculocutaneous nerve as the neurotizer. So this paper has been published in the PIS 2001, so-called traction approaching amputation of the major upper limb. I don't know. I want to move the second subject. I don't know Dr. Baba. Do you think the individual subject, individual question answer, or just keep going?
I think we'll do the. I think we'll do the questions at the end.
Okay, great. Now move to the second subject, Volkmann ischemic contracture, so-called VIC. They usually three terms describe the same pathology: acute compartment syndrome, Volkmann ischemia, Volkmann ischemic contracture. The three terminology to describe the same pathology. That because it's different time, different presentation, the same pathology due to ischemia. In pathology of VIC, you can see severe crush injury on the forearm or arm, and bullet injury, fracture. They usually associate obliteration of the brachial artery. And to just describe elbow or above elbow amputation after replantation. So they have such kind of the, you can see, those causes induce a significant forearm swelling. If you're not well treated, it will induce acute compartment syndrome. If you're not well treated again, the muscle edema, which causes muscle ischemia, then cause a Volkmann ischemia. If you're not well treated such kind of condition, then the muscle will infarct and degenerated and fibrotic, which cause and induce the Volkmann contracture. So it's kind of dynamic change, step by step. This is the case of Volkmann ischemia. He has severe crush and elbow. Just 2 weeks ago, I saw the patient 2 weeks ago, reported to me. I make a long incision. I found all the muscle just pale, fragile, and easy tear by the finger. The muscle is very easy to tear by the finger. So I took out all the muscle and closed the wound primarily. This is the other cases of ischemic contracture. So you can see all the muscle just ischemia, infarction, fat degeneration, and the fibrotic and the contracture. Another case of Volkmann contracture. You can see all the muscle. If you want to take it out, it's just kind of like a metal piece by piece. It's difficult to make a muscle excision, and also difficult to do the nerve neuralysis. Clinical picture just like this: tenderness and the muscle area, severe tenderness, and the flexion contracture of the wrist and the finger. If you want to do exercise, that means it will induce a severe pain. So such kind of patient, rehabilitation is very difficult because of pain. The other case like this, you see the muscle tenderness, and you also can see the tinea sign and the flexion contracture of the forearm, wrist, and the fingers. So the pathology, such kind of patient pathology, severity of muscle, usually deep seated muscle, so-called third layer muscle, were most severe affected. Then the second layer muscle, that's so-called flexor superficialis. Then wrist flexor, FCR, PL, palmar longus, FCU, this is the first layer. Usually frontal teres and the forearm extensor, they are usually healthy. Regarding to the nerve affected, medial nerve more affected than ulnar nerve, than radial nerve. This picture show you the drawing show you the degree of the Volkmann ischemic contracture. Minor degree means only the third layer affected. Moderate degree that means not only the deep layer, also the superficial layer. Severe degree that means not only the third layer, second layer, although also the first layer affected. I show you the case intraoperative finding. You can see the flexor T-stone profundus is kind of like this. It's contractural actually degeneration, and this is also this is the third layer, flexor T-stone profundus, flexor proximus longus, and the second layer, flexor T-stone cervicis. You can see the fat degeneration. And the superficial layer, FCR, you can see the fat degeneration. And frontal teres is here, it looks healthy. So clinical picture, as I just mentioned, like this. The tip for management of acute compartment syndrome, of course, you have to do the early fasciotomy to decrease the compartment syndrome, which causes soft tissue ischemia. Tip for management of Volkmann ischemia. So you can do the second look within 3 weeks to see the what kind of injury. Because at that moment you can easily to remove the muscle. You can easily to watch the nerve. So you can do the muscle teething test. The so-called muscle teething test, you can use a forceps or using the finger. It's very easy tear because it's fragile. Then those early infarct muscle excision is easier and the checking nerve. The purpose is you can remove the infarct muscle easier. You can do nerve repair if the rupture. Tendonitis is usually not necessary at this stage. You can reduce the nerve compression by the lateral fibrosis. You can preserve good wrenching of the passive joint movement. You can preserve adequate hand sensibility. You might have preserved intrinsic hand function. Extensive debridement is very important. You might direct the wound closure, or you can use a pre-skin prep or micronized prep or wound coverage first. Then patient go to the rehabilitation about 6 months. Then do the function-free muscle transplantation. Of course, if the bone non-union happen, then you can do the bone treatment first. After it, then do function-free muscle. I will say immediate function-free muscle transplantation for wound coverage and function restoration is advised because of poor wound bed and your inability to recognize the nerve damage. Such case, 2 weeks, I excise the muscle and no need to do the neurolysis. Then he got the intrinsic muscle. You can see the MP fraction is quite good. Then it just keep rehabilitation. Then after all, then you do function-free muscle. You can get such kind of good result. Extension finger flexion. This is a bullet injury in the arm, which caused obliteration of the brachial artery. 20 days, that means 3 weeks. Then I did the extensive debridement, take out all the infarct muscle. Then 1 year after, and you also can check the nerve and then repair the nerve. Then 1 year after, you can do the function-free muscle. This is remove the muscle. You can see from the deep muscle to the superficial muscle. So this is after regenerate. The extension is come back by itself, and the finger flexion is come back by the function-free muscle brachialis. So he got this. Of course, his intrinsic muscle not good recover, but extrinsic all are good. Then for the degree, for the severe type, that means the Volkmann contracture. The usually 3 stage is usually required. Stage 1, take out the muscle. Usually the muscle tear, and the muscle excision is typical. Usually like metal piece by piece. Then neurolysis is also typical. Then stage 2, rehabilitation. Usually at least 6 months, maybe 1 year. Then stage 3, function-free muscle. You might do 1 or 2. If the injury involves both flexor and extensor muscle, I recommend extensor first, then flexor following. Because if you primary reconstruction of finger flexor, because the power is too strong, then you do the second function-free muscle for extension. It's typical because each time the patient movement, they will move the flexor side. So I recommend extensor first, then flexor. In such case, severe Volkmann ischemic contracture, the 2 years after finger flexion, you can see extension recovered by itself. This is the added mild degree. You can see the ulnar nerve not good, medial nerve not good, claw finger, atrophy. This is after the reconstruction and get back, and also get back the nerve. So it's quite powerful. The other case, before intraoperative finding, you also see the nerve injury. Then after all reconstruction and the stage surgery, he got the maybe intrinsic IP extension not good, but EDC finger extension is good, and finger flexion by the function-free muscle. The other case is before You can see the tight, the flexor prolongus, flexor digitorum profundus. Then after reconstruction, you can see extension, finger flexion. The other case, you see if you use rehabilitation in the beginning, they're usually very difficult and closer. You see the pressure sore on the finger. So during the surgery, and it's after the total reconstruction, the full reconstruction, extension, finger flexion, after the function-free muscle for finger flexion. The other case, then you can see extension, flexion, even on recover by itself. The other case, intraoperative, before like this, after like this. This is two muscles, one for extension, one for finger flexion. The other case like this, then after the preserve certain intrinsic function, then after the function-free muscle, you see also recovery of the ulnar nerve. The other case, before and after. This is the case. He has a radial bone necrosis. So I took out the bone and using the one bone forearm. So one bone forearm surgery. Then stage 2 gratuitous for the finger extension, another gratuitous for finger flexion. So you can see extension and finger flexion. This paper has been published in the PRS 1996. Then move to the third subject, major muscle and nerve loss. It means the muscle compartment loss. Maybe the flexor, maybe the arm flexor compartment, extensor compartment of forearm, flexor compartment of the forearm. They usually concomitant injury with the nerve and concomitant injury with the vessel, maybe bone fracture or skin loss. Case like this, very extensive. Because the most injury are about extensive and complex. So such kind of group, usually people they refer to me, more than half of group patient advised to undergo amputation, but patient deny, then come to see me. Regular tendon and muscle transfer is frequently not possible, and that's the moment. Function-free muscle transplantation is available or perhaps the last obstruction option. Usually good prognosis if you make a good handle. I corrected 40 patients. They might caused by the machine, traffic accident, electric burn, gunshot wound, the compartment elbow flexor, forearm extensor, forearm flexor. You can see more than half patients need the additional free tissue transport wound coverage. And 1/4 patient and 1.4 patient, 1.4 preps applied for the functional restoration in this kind of patient. Because the successful function-free muscle transplantation will make the good prognosis. So determine the factor of the successful function-free muscle transplantation is should be always keep in mind. You need healthy, innovative motor nerve. You need good condition of the recipient bed, good condition of skin coverage, and you selecting the good muscle based on the excursion or strength. Then priority of functional muscle always keep in mind, it is for functional restoration. It's not for wound coverage. So it's better perform as an elective, well-prepared case. Not good for acute contaminated cases. So such kind of injury, they always need the stage surgery. Stage 1, extensive debridement and wound coverage. You might need free myocutaneous flap or skin flap for wound coverage. Skin graft or muscle flap with skin graft is unwise because you need the second stage reconstruction. The skin graft, you cannot make incision there. The stage 2, then you do no repair. It's better perform earlier, less than 3 weeks. Then stage 3, you go to the rehabilitation. Then finally, you go to function-free muscle transplantation. This case, you can see extensive, it's open wound with extensive necrosis of the arm and forearm muscle. So you can see this, the vessel, you see vein graft called artery, embolectomy, radial artery, extensive debridement, and the free rectus femoris, myocardial for wound coverage. Fortunately, in this case, median ulnar are still in continuity. So stage 2, you do the puncturing muscle for biceps. Stage 3, you do the puncturing muscle for finger flexion. So you see he has good elbow flexion and good finger flexion. This case, open type 3 humerus fracture with axial artery occlusion. Stage 1, external fixation and graft for the artery. Fasciotomy of the forearm, rectus femoris, myocardial spray for wound coverage. Stage 2, crutches for elbow flexion. Stage 3, rectus femoris for extension. Stage 4, crutches for finger flexion. So you can see that actually he has a 4 flap in the arm and the forearm. And he get a good elbow flexion, also get the finger extension and the finger flexion. This patient now become one university professor. I think he's associate professor. He looks like young, but he's happy. He saw me. He came to see me. Just say hello to me. So I think he is happy about the result. This case is compression and abstraction injury, which called the distal avulsion of the biceps muscle and the nerve, avascularity of biceps and brachialis muscle. So you just take it out and close the wound, then rehabilitation. This is before reconstruction. This is after puncturing pre-muscle. You get powerful elbow flexion. This case is electric burn, a large open wound, cause necrosis of the elbow flexor. So in the beginning, I use the pedicle LD myocardial spray for wound coverage. Then I do puncturing crutches for elbow flexion. You can see the 2 flaps here and quite powerful the elbow flexor. This is a case of complex injury. It's injury by the noodle, noodle crushing machine. It's kind of segmental loss of the radial bone, avascular necrosis of the extensor muscle, radial artery avulsion, radial nerve also avulsion. I use a fibula. This is a fibula. Fibula associated lateral half soleus, compound flap. The bone is for radius, and the muscle is for finger extension, using the posterior interosseous nerve. One stage, we got this kind of result. This is extensive and contaminated wound in the elbow back after the extensive debridement and wound coverage with latissimus dorsi. Then second stage, you do the puncturing prima, tendon transfer. It's not puncturing prima because the flexor is good. So you do the 3 muscle transfer, local muscle transfer. You got the wrist extension, finger extension, and the thumb. 3 tendon transfer. This case, if you do the puncturing pre-muscle transplantation in a contaminated wound, 1-stage procedure, you cannot get such kind of good result as the previous one. You only get M2, wrist extension and the finger extension. You only get M2. So the situation you have to judge. Okay, so I will make a brief conclusion for this morning talk. Most complex injury of the upper extremity should be considered for salvage. Of course, it requires a multidisciplinary approach to handle bone, vessel, muscle, nerve, and skin. Initial treatment is crucial for outcome. Secondary or stage reconstruction is very often required. I will tell you, functional muscle transplantation is a very useful weapon. This paper, similar paper, published in the different journal and the books. You can see regarding the same subject. Thank you. This is my talk.
Professor Chuang, thank you so much for a fantastic talk and really incredible cases. You've shown some really devastating injuries and some fantastic results. My question for you is, are you seeing the same frequency of these severe cases as you did, let's say 10 years ago, 20 years ago, 30 years ago, or are the severe injuries going down in number in your practice?
Because because recently, maybe recent 20 years, I almost shifting my concentration into the clean wound, such as the brachial injury, cross type, such as facial paralysis, and I shifting such kind of big open wound to the young generation. So I might not answer your question, but I think it's decreased. I think it's decreased. But sometimes I heard some young doctor present the same cases in the mortality and morbidity. I think they still forget how to good handle of such kind of the big wound. They still forget. This is why today I just using my past experience to remind you such kind of my experience, personal experience, just as your reference.
Yeah, I think we've seen something similar in that a lot of the more devastating injuries and amputations higher up are probably not as frequent, maybe because of increased safety at work, maybe.
Yes.
And in talking to some of our colleagues around the world, it also seems like at least here in the West, that the numbers seem to have gone down a little bit. So I think that's why it's so good to see your experience, so that if you do see a bad injury like that, you know what to do. The next question I have is more of a technical question with regards to the free functional muscle transplantation. When you're doing a free functional muscle gracilis for finger flexion, and you've shortened the forearm significantly, let's say 5 or 7 centimeters, where do you prefer to attach your proximal gracilis on the humerus to be able to achieve enough length on the muscle for it to work well?
I usually attach the proximal side to the coracoid process of the scapula. Then I prefer to use the original mother nerve, musculocutaneous nerve, instead of using the spinal accessory nerve, intercostal nerve. Except maybe if the musculocutaneous nerve has severe injury. Even though I still prefer to use a musculocutaneous nerve, original mother nerve. And distal, I always attach to the distal bicep tendon. Distal bicep tendon. This is in the arm situation.
Great. And then what about for finger flexors? For the finger flexion, where on the humerus do you, especially in a shortened forearm, with the gracilis muscle being as long as it is, where on the humerus do you prefer to attach the gracilis to?
Those distal third of humerus. You attach to the periosteum of the distal third of humerus. Extend more upward.
Do you use suture anchors, or what's your method of fixation? Is it anchors, or is it just bone tunnels, or what do you use?
I use the periosteum. If the periosteum is too thin, then I will make a bone hole. I use a bone hole using the wire, two wire to fix the proximal stump.
Got it. Now, you mentioned that proximally, your preference is to use a musculocutaneous, and that makes a lot of sense. In a case where the musculocutaneous is either not available or severely injured, is your second choice an intercostal transfer? Do you use a thoracodorsal transfer? What's your next kind of option for that?
Spinal accessory nerve.
Spinal accessory.
At that moment, the proximal attachment should be moved to the clavicle, not at the coracoid process. You have to move up. It's still okay. So spinal accessory is my second choice. Intercostal nerve, my third choice. I don't like use a branch of another nerve, branch of medial nerve. I would say it's the function not good. So second choice spinal accessory. Third choice intercostal nerve. Yeah.
Got it. I know Dr. Greg Buncke is on the webinar. I was going to call on Greg. Greg, do you have any questions or comments for Professor Chuang?
I do. David, wonderful
Yes.
talk, great cases, unbelievable cases. I love the fact that you're doing 2 muscle flaps, 2 muscle transplantations. I think it's great that you use the term transplantation rather than free flap or transfer. It is really a transplant, and I think that's something that my father used to talk about a lot, is that it's not a transfer like a tendon transfer, it's really a transplant, and you say muscle transplantation, which is wonderful. I wanted to ask you about how you determine where you're going to plug into the recipient. I think that you do so many flaps on these badly damaged upper extremities. How do you know where you can get into vessels? Do you do arteriograms first? Do you just use the Doppler? Do you just go and look for vessels? How do you go about doing that preoperatively?
This is what I say in the slide. The initial management is crucial for the outcome. So you better explore to check it. Early explore, then you can understand what kind of injury it is available to be used or is not available. If the muscle is dead, just take it out. You leave the muscle there, the wound still can be healed well. However, the muscle die, necrotic and fibrotic. So I emphasize early to explore the wound to see what happened. Then you can understand what kind of injury of the muscle, what kind of injury of the nerve.
I see.
Is answer okay?
Yeah, I just wondered how do you find vessels to hook your transplants to? Because it's oftentimes such a badly damaged arm. Is there a trick that you have for finding vessels?
Usually my function-free muscle transplantation is on the the late stage. What I mean is all the injury tissue they already recovery, from the bad to good to the better. Is get softer. You very easy to judge the nerve or the vessel is healthy or not. So to me, if you do the function-free muscle transplantation in the acute stage, maybe it's difficult for you. But my case is, I think I did not have such kind of bother. I did not have such kind of bothering. So using the functional muscle transplantation is usually when you see the nerve is healthy, then it is healthy. If the nerve is not healthy, then you just get a healthy nerve, healthy stump. It's easy to judge. In acute stage, they're usually using the not function-free muscle. They just follow free tissue transfer for the wound coverage. So it's not the what I say is honestly, if you fail, then just change another free flap for wound coverage, right? Yep. So to me, in the late stage, don't worry about it. I never routinely do the vascular angiography. I never do that. I just intraoperatively make a judge.
Got it. That's experience.
You can say like
Thank
that.
you.
Yeah, you're welcome.
Great, Professor Chuang. It looks like it looks like Professor Balakrishnan is on. Do you have a question or comment, Professor Bala? Your microphone is muted. You'll need to unmute your microphone.
Now, some of the old cases of Volkmann ischemic contracture. Many times when we explore, the nerve is intact. The only problem is the vessel. And we repair the vessel, they get better. You get a good movement. Having any experience of that, where you do only a nerve blood vessel repair. And this is some of the fold that we may be seeing them after a couple of years, where there is no function, but there is no pulse also. So by just doing the blood vessel repair, we are able to get the movement. Have we come across such cases?
Babak, can you repeat his question or his words again?
Actually, Professor Bala, would you mind repeating that for me as well? Sorry.
Yeah. See, the problem is the cold cases. You see a Volkmann ischemic contracture maybe after 5-6 years. That time, there is no movement and there is also no pulsation. And some protective sensation is present. By repairing the blood vessel, we get back the movements of the hand. Do you have any occasion? I have done a couple of cases where I just did only the repair of the vessel, not anything with the nerve or the muscle.
Oh, so
It's only the question of repairing the vessel, blood vessel.
so you're saying that in Volkmann's contractures, you've gone in and just repaired the vessels and the muscles have been able to recover?
Yes.
Ah,
Because those they never had a blood supply because of the injury. Now, when you augment the supply, the nerve get again re-innervated and get the movements.
got it. Professor Chuang, Professor Bala is mentioning that in, I guess, in earlier Volkmann's where the muscle has not necrosed yet, in their experience, they have gone in and reconstructed the blood supply, and they've noticed that they've been able to get better recovery of the nerves and the muscles. Do you have you seen the same thing, and do you have any experience with that?
You know, when I published this article, this one of the reviewer say make the criticize say if you make like Baba Krishna say, if you make the vessel repair, then the muscle may recover in the future. But I have make such kind of comparison. Early take out the muscle, or let just watching how the recovery of the muscle. These two difference, I recommend. I still prefer early. Even the muscle looks okay. You do the vessel repair. You expect the muscle can recover even like that. This is why I mentioned in my slide the so-called muscle testing. The muscle testing means if you easily can break the muscle by your finger or by your forceps, that muscle is not good. If you leave there, it's still there, it still survive, one still can feel well, but it's not good muscle. So this is why I say you can do the muscle test as in the slide show. So you did the muscle test, you steer the muscle. If it's easy to tear, just take it out. You don't need to leave it there, even after the vessel repair. You still take it out.
Got
it. It's good for the later, because we don't worry about the later reconstruction. As I mentioned, the function-free muscle is a very good weapon. You have such weapons, so you don't need to do. You don't need to worry about the remove the muscle. Maybe some muscle can recover. No, I don't think so, because those muscles later will get trouble.
Got it. Great. Well, thank you so much for that. And thank you so much for the question, Professor Balakrishnan. Thanks so much. It looks like we don't have any other questions. So Professor Chuang, I wanted to thank you again for taking the time out of your busy schedule. It's really our honor to have you. We would obviously prefer it to be in person, but this is the next best thing that we have right now. So thanks again, and I'm looking forward to hopefully seeing you soon.
Yeah, me too. Looking forward to see you too soon.
Excellent.
Okay. Thank
Say
you,
hello
everyone.
to everyone in Taipei. Thanks so much. Bye-bye.
Thank you. Bye-bye.